All right, thank you everyone for attending today's talk on clinical and public health interventions for tobacco and cannabis. It is with great pleasure to introduce you to our speaker for today, Dr. Eliza Tong. Dr. Tong is a professor in the Department of Internal Medicine and a general internist at UC Davis Health. Additionally, she serves as medical director of the Stop Tobacco program at the UC Davis Comprehensive Cancer Center. Dr. Tong's research interests are in tobacco control policy and cessation, with special interest in health services delivery of tobacco treatment, interventions to address tobacco and cancer disparities, and the behavioral impact of smoke and tobacco-free policies. She has founded and led UC Quits, and now California Quits, a statewide project funded by the California Tobacco Control Program, which supports the integration of tobacco treatment into health systems in partnership with the California Department of Healthcare Services. She has led tobacco interventions targeting diverse populations and works closely with tobacco treatment partners at the UC Davis Health Management Education Center and the California Smokers Helpline. Please join me today in welcoming Dr. Eliza Tong.
Thanks so much, Cindy. Well, hello, everyone. It's a pleasure to be here, and we had a very nice session with the students beforehand, and I just want to acknowledge also my friend and colleague, Kim Homer Vagadori from California Youth Advocacy Network, because it was 5 years ago, I think, that we spoke together about flavored tobacco at that time. So it's kind of coming back full circle to be asked to talk about tobacco and cannabis while we're at it. And I just want to recognize also that when we talk about tobacco, we're talking about commercial tobacco because we want to acknowledge that there are indigenous and Native American populations that use tobacco for ceremonial and sacred purposes, and commercial tobacco refers to the tobacco that has chemicals added to it to make it more addictive and contributes to disease and death. So this is a big topic. I don't have all the answers. I just want to say that now. But things that I realize as we just launched our first undergrad seminar in public health for tobacco last spring, and I'm just realizing more and more we need to educate everyone on the history of tobacco control, especially in California, because we've had so much success, but what is that historical knowledge that we have to kind of encounter new challenges? So it's been 60 years since the Surgeon General's report. What do we know from there before and to now? So cigarette smoking, if you watch all those old black and white movies, it's prevalent everywhere. Humphrey Bogart smoking, and even you'll see like some old advertisements where, it always shocks me when I see this one that more doctors recommend, Camels because this one's better for your throat. And as soon as people started getting more studies, though, saying, hey, there's actually people getting cancer and people are dying from it, the tobacco industry, started this kind of marketing and public relations campaign to say, we know there's concern, but we'll do everything we can in everyone's, public health interests. But we'll see from later on that was more to create doubt and more to just keep making profits for themselves in selling cigarettes. But what we did know from all this kind of scientific research gathering from biological and epidemiological evidence, we had our first Surgeon General's report saying that smoking causes disease, especially lung cancer. And I like to tell the med students that there was a med student who did one of the first early epi studies where he went around on rounds and said, this person's a smoker, this person has lung cancer, this person's a non-smoker, this person, do they have lung cancer or not? And showed, just that they were able to demonstrate, that was one of the early studies demonstrating smoking is associated with lung cancer. So 60 years from then, that we first knew about this, that there was this scientific conclusion, it's taken us this long to, develop more public health and healthcare changes to help people who smoke to quit. So what else did we see? So that was in the 70s and 80s, we saw not just being worried about people who use cigarettes, but we also learned that we needed to be concerned about the health of non-smokers as well. And these health concerns, the tobacco industry tried to pivot. They tried to create other products that seemed healthier. So tar, if you did a little mouse experiment and you painted the back of the mouse, that was a thing the black nasty stuff that would create, a tumor on the mouse's back. So then they started selling products that said, oh, we are light cigarettes, we're low tar cigarettes. And it took years for us to figure out that's actually not the case, that those kind of products actually didn't change anything with the disease and death. So one of those lessons learned of new doesn't necessarily mean better. Sometimes it will take us years to find out, what are the real health effects. But, marketing, they are very good at marketing products that seem better for you or fun for you or healthier for you. But are they really? It takes years to find that out. But one report that did change a lot of public policy was the accumulation of evidence for non-smokers' health. And the Surgeon General's report in 1986 was updated to say that secondhand smoke exposure in non-smokers causes disease, including lung cancer, which was a huge conclusion, and also disease in children. They have smaller lungs and, a lot of asthma or other disease. And then also this idea that separating smokers and non-smokers doesn't eliminate exposure. And one of the best jokes I've heard in all the tobacco research conferences was, to have a smoking and non-smoking section is like having a swimming pool with a peeing and non-peeing section. Like, it doesn't matter, it just kind of goes all in between. So with that scientific conclusion, our California Department of Public Health, California Tobacco Control Program, was funded because of our taxpayers through Proposition 99. It was a 25-cent tobacco tax. You'll see at this journal title, it says "The Quarter That Changed the World," because this created funding for public health programs, it created funding for school prevention education, it created funding for research, and I'm funded by that research program also, which is housed under UC Office of the President, TRDRP. And because this public health program, which still is here today, it not only had a state program, but it also funded local county health departments to promote public policy and social norm change so that we could have more of a tobacco-free environment where we could support people in quitting. And then there was also a groundbreaking media campaign which tried to change social norms, to help people understand secondhand smoke was harmful to others, which is a super powerful concept, even more powerful than the idea that smoking is harmful to your own health. The idea that you're harming your pet, your family, your neighbor. That's where sometimes people feel there's stigma, but it's also just changing that norm that there's non-smokers' rights. And then also a rigorous evaluation program as well to understand, what is the effects of these programs over time. And on the graph to the right, John Pierce at UC San Diego is one of the great epidemiologists demonstrating this, that our trends in lung cancer deaths was actually lung cancer incidence and death was actually lower, accelerating faster than the rest of the United States. And you start seeing that change happen around the time of the tobacco control program here in California being implemented. And it takes many years for you to develop lung cancer, so some of this may be related to some of those immediate health effects from having more smoke-free areas. What did we see in the 1990s to 2000s? I kind of alluded to this to the students before, that there were whistleblowers and tobacco industry documents that started coming out. Before, you could not sue the tobacco companies and win. There were always people who said, I died, my father died of lung cancer, and then the tobacco companies would say, well, you knew that smoking was bad for you, it's your fault. So, they were no one was ever able to successfully sue them. But when the whistleblowers started having all these internal documents come out that say they knew nicotine was addictive, that they were manipulating the product, that they were manipulating science and scientific conclusions. So all of this led to the state attorney generals actually did this massive they all actually sued for Medicaid costs of health care with the tobacco industry. And there's something that was called the Master Settlement Agreement, which was paid out to all the states, $196 billion until 2025. Or you could cash out early, which a lot of states did, and a lot of them used it for other things like fixing sidewalks or whatnot. But that was something that was a landmark lawsuit in the interest of public health and the healthcare costs that everybody was paying for as a taxpayer. So other landmarks throughout this, so 2006, and I remember when this report came out, and the Surgeon General at the time, I believe was Richard Carmona, they came out with this groundbreaking statement: there is no safe level of smoke exposure. As I've had people ask me, well, what's the threshold effect? How much, a little bit's okay, right? I mean, I'm not gonna die of cancer right away. Well, what we understand from the science, and the left-hand side shows this, it's a little bit complicated graph, I apologize. But for cancer, it's a dose-response relationship over time. The more toxin you have, the more likely your cells are gonna mutate and you're gonna develop cancer. But what we now understand, cardiovascular disease, it's not just about clogging your arteries with cholesterol. We now understand there are immediate effects from inflammation. So it doesn't matter if it's cigarette smoke necessarily, wildfire smoke. You guys know, if you lived in California, you can't breathe. But more than that, your cardiovascular system starts having these other health effects like platelet aggregation or endothelial dysfunction, where the insides of your blood vessels start getting inflamed. And that kind of inflammation can cause you to have immediate health effects like heart attacks or strokes. So those things, we see those kind of health effects within 1 year. I mean, when we talk about cancer, those are years, decades, but all the cardiovascular disease, the pulmonary disease, we worry about, much more immediate than that. So this was a groundbreaking conclusion that actually changed a lot of policy, not just in California, but the rest of the United States started having comprehensive smoke-free laws. And this is a map of the US on the right. And I just want to note that California, even though it's labeled here that it wasn't quite comprehensive smoke-free laws, they later fixed some of the loopholes, and so we are considered to have a comprehensive smoke-free law in terms of workplaces, restaurants, and bars. And now going on to, just one more mention about lawsuits. So that was with the state attorney generals. There was a US Department of Justice lawsuit also with RICO, which is Racketeer Influence and Corrupt Organizations. That's what they used to get the mob. And they concluded that the industry continues to engage in and execute a 50-year scheme to defraud the public on health effects and marketing to children. Initially, they were just asked to, they said, okay, you already paid out all this money to all the states, but hey, can you make some corrective statements? And I remember laughing because they were just kind of like middle of the night little black and white little things, almost like the little warning on your cigarette pack that just kind of flew by. But later on they were asked to make it a little bit more public. But I don't know if any of you have seen this, but these are some of the statements that they were asked to make in terms of the wrongdoing that they had done before. So reboot, the industry wanted to reboot also, and what is the federal government going to do about this also? So the 2009 Food and Drug Administration finally had authority to regulate tobacco products, to regulate the manufacture, distribution, and marketing of tobacco products, and there's approval needed actually to market or make cessation claims or reduced harm claims. This is, as many of you might know, things that at the federal level work very slow. So in real life, how does this translate to all the stuff you're seeing? What's out there with the industry products is a lot different than what's actually being, the FDA is able to take time to process and regulate. So there's actually only, some of these products, like the new products that are vapes that are approved, there's only a handful. So I was just sharing with the students earlier, what you see out there is kind of buyers beware, like you're not really sure what's in them. And at the time, FDA also banned flavors in cigarettes except menthol, because they said, oh, that's just a preference. We need to keep that. And then there was also delays at the national level that, is one of those public policy lessons we learn is things that happen at the national and federal level takes a lot longer than what you can do at the local level. Just one more thing about menthol cigarettes, that it was being exempted from being a flavor. Kudos to our African American tobacco control colleagues who kept up the drumbeat saying this is actually harming our communities because there's aggressive marketing. And so this has been something that, has been decades where people from the African American community don't feel that they're marketed, they feel that it's just something that everybody does. But actually, this is something that's very intentional, and how do we undo all that? Okay, and finally, almost catching up on my timeline, in 2014, that Surgeon General's report also added more diseases that smoking causes, if you can believe it. And also, here's just a reflection that, the annual deaths from smoking, it's the leading preventable cause of death. It's not just lung cancer. Everybody thinks about lung cancer, but heart disease, there are actually more heart disease deaths than lung cancer deaths, and then also lung disease as well. Also in this figure are deaths related to secondhand smoke exposure in non-users. So the figure I like to show is on the right because it's just a list that the red is all the diseases that the Surgeon General's report added. So now there's 12 types of cancer that smoking causes, so it's not just lung cancer. There's one liquid cancer, they like to call it liquid. It's AML, acute myeloid leukemia, that's caused by smoking. We don't know that many other factors that causes that. A host of other diseases, and then also chronic disease, not just cardiovascular and lung disease, but diabetes. We think of diabetes as a cardiovascular disease, metabolic issues, and then also we have to worry about infection as well, that it reduces your immune response, and also, causes you to have other diseases that, like tuberculosis. So. My rheumatologic colleagues are all excited to see rheumatoid arthritis on here too, because if you think about it, your immune function is also suppressed. So I like to say to people, as a general medicine doc, I think of tobacco as affecting many different things. If I see someone using a tobacco product, I immediately, my red alert goes up because I start thinking about all these other things. Mental health isn't listed on here too, but we know that this is also very important where, is it causing or is it people withdrawing? People are having worse mental health symptoms. This is also another key factor maybe driving some of that behavior. Okay, now finally catching up to 2016. So it was a weird year because on one hand, there was a huge tobacco win. Where we had, I mentioned the 25-cent tobacco tax. Well, that wasn't cutting it so much anymore. Proposition 56, we got a $2 additional tobacco tax, which we know tobacco taxes and public policies are the things that drive behavior the most. And I've had people say to me, oh, it's too expensive, I need to quit now. Okay, I've been wanting to quit, now I really should quit because I just can't afford this, it's not gonna make sense. So we know already that's one of the main drivers of behavior. And so where else does that $2 tobacco tax go besides public health and education? It started also helping to fund our Medi-Cal providers and graduate medical education. Although there was no stipulation that you needed to do anything related to tobacco at all. We're just gonna try to support the people for preventive and also sick care. There was also at the time Tobacco 21, so no sales to people under 21 years old. So it seemed like some big wins. And then to mix it all kind of a little bit together was Proposition 64 that got passed at the same time. Recreational cannabis was legalized for adults 21 and over. So, I think we talked earlier before that this was, great that there was decriminalization, but there was also this thought of, we know what's happened with the tobacco industry, what happens when they get into the cannabis industry? But, so we'll see what happens. Just final words on treatment for tobacco, because I was talking a lot about public health and prevention. We do know that quitting has immediate health benefits. There's a new not new, but 2020 smoking cessation Surgeon General's report, which encapsulates all this about how we really should be integrating tobacco treatment throughout everything we do, including cancer care. Now that people with cancer care, when I was in training, we didn't have many things to help people with cancer, and now people are living longer. We know that this is one of the things that will help them have a better quality of life and live longer if tobacco treatment is part of their cancer care. So again, it's that cardiovascular benefit and your lung benefit that within 1 year you see people living longer. What do we have to help people quit? Just a quick reminder, if you don't know already, there's 7 different medications that the Food and Drug Administration has approved for smoking cessation. So 5 of them are nicotine replacement products, and these are all lower levels of nicotine than what you get within 1 minute of a cigarette, which it gets into your bloodstream really fast. These are all much lower levels. So the idea is that you don't go into withdrawal, you don't get irritable, you don't get angry, or feeling like you need a craving for a cigarette. And there's 2 pills. Bupropion is one, which is also used as an antidepressant, and varenicline, which is now generic, so it's cheaper now and more available. And all of these are covered by Medi-Cal, but what you probably see, and at least when I went to Target, if you try to buy it over the counter, nicotine patch box is $60. How much is a pack of cigarettes? Like, which one would you choose? Are you going to wait to go to your doctor to get a prescription so you can get it covered? Maybe you don't know that it's covered. So, sometimes we think about access to, barriers to care. What are people's understanding of how to quit? Even if 70% of people want to quit, how are they going to quit? But any of these medications, and this graph to the right just shows that any of these medications help with long-term quitting, some a little bit more than others. And what we try to do now, especially when we don't know how to dose vaping, all these trials were mostly based on cigarette smoking, and all the vaping stuff and all the nicotine concentrations are, we don't even know what we're doing. Sometimes we just have to keep titrating. We at least know we should combine some of these products, and just, maybe we need to keep going up on the dose until we can try to help people with some of their symptoms. And officially, the U.S. Preventive Services Task Force, which makes all the clinical recommendations and guidelines that we go by in healthcare, they still deem that there's insufficient evidence to recommend e-cigarettes for quitting. And you'll see some studies out there where, like in the UK, which is a totally different regulatory environment, where they said e-cigarettes help you quit smoking. Well, sometimes some of them are just switching over to the e-cigarettes, and they stop using they're using the e-cigarettes, but they stop the cigarettes. Is that really quitting? You have to be careful of the terminology and look and read carefully to see, did the people stop all tobacco and nicotine products? Because ultimately, that is what we want to do, is to try to help people be free from tobacco and nicotine addiction, because nicotine is one of the most addictive substances. And also, just a shout out to our free quit line service. Who are the people from UC San Diego? Just so you guys know, the state quit line has been there, and almost since the state tobacco program has been in place. And the New England Journal of Medicine is one of our top tier health journals, and they published a landmark study saying, that the healthcare counseling that they do, with motivational interviewing and behavior change, 20 to 30 minutes coaching, that it helps people double their chances of long-term quitting. And now they've come, it used to be called California Smokers Helpline, 1-800-NO-BUTS. Now it's called Kick It California. And then we did a study, one of the UC Quit studies that I did was to connect all of our healthcare systems and the 5 UC health systems with the quit line. So now you can just push a button and then have your patient get called in a couple days. And we showed, over 7 years, how this benefited our patients. And you can see that a lot of them are very diverse and have different medical conditions. And also that the quit rate is about the same for long-term. We know that tobacco treatment is an ongoing thing where it's not just a one and done. Sometimes, it takes at least, they say in public health, like 12 times to quit for good. So we know sometimes this is a cyclic thing that we need to keep offering to people. Okay, that was Tobacco 101. That probably could have been enough for my talk. But just want to move on to new products and new problems, and I'll try to go faster on this. As all of you know, and all of you are the younger generation, vaping has become a youth epidemic, right? That was also determined by the Surgeon General. They came out with a report on it, and these are some of the figures from the California Tobacco Control Program. And now, as Kim was talking with the students earlier, these products, they're bigger, cheaper, and stronger. Before, years ago, we were all worried about Juul, and now that's kind of fallen off to the wayside. But now there are things that have even more nicotine in them and way more puffs in them. The providers, we don't know anything about this. They're your moms and dads who don't know that these products were being used at school in the first place. So how do we deal with this? One thought is maybe we need to start checking labs. There is a nicotine metabolite called cotinine where we maybe need to monitor this more frequently so that we actually understand not just, I just puff a couple things a day, I just use this little bottle once a week. When I've tallied it up, I'm like, oh my gosh, you are using 2 packs of cigarettes worth of nicotine. I have to do all those conversions in my head. A lab might be easier. And then all these oral nicotine products that the tobacco industry is pushing out, is confusing a lot of people too, where I've had patients come and say, hey, I think look, I'm not smoking cigarettes, but look at this, what I have. And this thing says it's non-tobacco too, so I feel like I'm doing something good for my health. Well, the dental providers will tell you these oral nicotine products and oral health is very much tied to your cardiovascular health. We see the nicotine content of these things, or the cotinine levels, like 2 to 3 times the level of what you see in cigarettes. So what you're absorbing and sticking here in your mouth, it's actually causing a lot more cardiovascular potential, hypertension, all these other things than maybe what people really appreciate. Let me just go through some of these slides quickly. This just shows you how in California there was this decline in cigarettes, but now we're seeing it kind of bolstered up by vaping. Our decline in tobacco use is now kind of being buffered by this as people switch to different products and as the younger generation uses vapes. There are new, we mentioned some of those other tobacco industry products, but I don't know if anybody's heard of these heat not burn products. IQOS, it's like a little mini cigarette that you heat up, and it's supposed to have less secondhand smoke, but actually at UCSF, one of the studies they did showed that your liver labs get higher than a cigarette, than people who smoke a cigarette. So we're not really quite sure what happens. Sometimes people say there's nothing worse than burning a cigarette. We don't actually know. We're going to see what happens with some of these products. And then again, so there's these synthetics that are coming out too, and we're seeing increasing use of these products by people, even though we don't know what health message to give them. This is just to remind us that there are many different communities, diverse communities that use tobacco, and sometimes it's in their environment as well. So, and also, even if the totals are high, sometimes smaller groups like American Indians, for example, have high prevalence, even though the total numbers aren't high on this graph. So just want to recognize here that we have to think about health equity, rural populations, LGBTQ. These are things that public health people think about. Healthcare, a little bit less so, but when we look at population health, we do need to recognize health equity is important. Another complicated slide, but this is from Kim, just to acknowledge that there is tobacco and marijuana use among high school students, these are some of the trends that you'll see for current use. So we are monitoring them, and we're seeing that they're using these newer products as well. And just to shout out that these are higher potency products. The little Juul pod I showed before, that's supposed to be the equivalent of 1 pack of cigarettes. And the tobacco industry had already freebased the nicotine in the cigarettes to make it more addictive. Now you have nicotine salts, which are even more bioavailable. So I've had people say, I use 3 or 4 pods a day. I feel okay. And I'm like, I don't know that you realize how much you're consuming. And especially for our young people, and they say the brain is still developing through 25, this and the potent cannabis that's out there now, which is 3 times more potent than maybe back in the 60s, we need to be thinking about this as higher risk. What's in the aerosol? And you might have heard people like, oh, it's just vapor, it's okay. There's actually a lot of stuff in there. Even if it has less carcinogens, the CDC likes to say it's still not safe. There's VOCs, there's ultrafine particles, the same things that cause the inflammation. There's still cancer-causing chemicals, and because of all the lithium battery stuff in there, there's also these heavy metals. So what you see is not necessarily what you get, and we're still learning about this. I find it super interesting when we had to do the flavored tobacco talk, what happens when you inhale and not eat something flavored. And this is, again, something we're learning about. I'll mention the vitamin E thing. I don't know. I've encountered some of the UC Davis students vaping melatonin, and I'm like, why are you vaping it? Why don't you just eat it? But so if you vape vitamin E, which looks like cannabis, apparently this is the thing that is the reason why we think we see some of the new diseases. It causes a toxic gas called catene, and we think that may be why we've been seeing some of the lung injury from vaping. Cinnamon flavor is especially bad for you and toxic. Mint and menthol, there was a study done by Duke researchers that showed that the mint and menthol flavored e-cigarettes had actually way higher levels of a carcinogen called polygon than what was in a cigarette. So we're learning about what these flavors actually do as well. And mint and menthol, besides it being a marketing thing, we're now understanding it makes it easier for you to start and harder to quit. So some of these health disparities we see, especially in the African American population or Pacific Islander populations, it's some of these chemicals that are added. Just to briefly show, there's growing evidence about health risks that we're understanding from compiling all these studies, and inevitably there will be more Surgeon General reports. But we're learning now that not only does e-cigarettes that they have health harms, but that if you're doing both cigarettes and e-cigarettes, you're probably compounding your health risks. So this concern about dual use, which hasn't really gotten out into the healthcare area, but we need to start thinking about asking about multiple products. Just briefly about EVALI. Did anybody remember EVALI? This was the epidemic before COVID. Right before COVID shut down. There were young people who were getting sick, so sick that they were getting intubated and even dying. Well, the people who died were a little bit older and had chronic disease. But this was something that really shocked a lot of people in healthcare. And again, some of it is thought to be maybe related to vaping vitamin E, but we don't really know because they did only lung washings in maybe 50 of folks, and there were other chemicals in there too. So this is something where this is a new disease entity from vaping, but we don't really fully understand how to diagnose this, except if you rule out everything else. And just an example of this, my UC Davis pediatric colleagues, they published a paper about how EVALI can look like COVID, and they intubated these young people, but once they got the negative COVID test, they're like, okay, what else is going on? And then they found out it was because the person was vaping. And it can happen really rapidly. The x-ray on the bottom is within 24 hours. You can white out really fast. The good news is, after all those challenges, on the public policy side is that our state and many local laws too passed, I believe we were the second state that finally passed a ban on flavored tobacco being sold in retail stores. And so this is relatively new, and we were all very happy about it, and then realized, oh, it's actually, not just policy adoption, it's also policy implementation. So one of the things our Policy Research Center was involved with was demonstrating there is an enforcement issue because there's these new products coming out that are, used to be menthol, now they're called green, now they're called chill. So is that a flavor? Is green a flavor? So our enforcement agencies were having a lot of challenges. And so now there's an unflavored list that was just passed, just signed by Governor Newsom. And then also there's an ability for the enforcement agencies to actually seize the products, not just say, hey, you're not supposed to sell that. and walk away. They can actually take it now. So I think this is something that we're going to be demonstrating in California and learning from, and see what else needs to be done that enforcement agencies need. Just a quick shout out on the environmental part, as we're learning about tobacco, that there's also a lot of issues with waste. You guys might know that cigarette butts are not biodegradable. They got those plastic filters and they leach toxins and into our water and oceans. And that's the most common thing that is picked up for litter in California, especially beaches. But now we got to deal also with all this e-cigarette lithium, waste. Even though you used up that nicotine, in the pod, it's still, the residue is actually still toxic. Nicotine is actually an insecticide. So they need to be disposed of as hazardous waste, not just toss it in the trash. And that's something our UC Davis students, if some of you might be involved in our study with our tobacco tracker, but we're trying to educate and have crowdsourced reports about what people see out there. Okay. That was pretty fast, but let me go even faster on the cannabis part, because this is a huge topic, but just want to have some points, because I think there's some lessons learned from tobacco that need to be applied to cannabis, which doesn't have that same public health infrastructure, that same public health background. It started off with as you saw, the proposition to allow recreational cannabis, and we've got much more potent stuff out there now. Kim pointed out there's, stuff that's mixed together with nicotine. The products are there's these gray zones, there's these blurred lines. So we kind of need to take these lessons learned from tobacco and think about how to think about public health and healthcare. There was a great New York Times article out. I hope you guys all read this, because it really resonated to me as a provider, hearing some of the patient voices where they were like, I didn't realize cannabis could do this to me. I thought I was treating my anxiety, but it was making it worse. Why didn't my doctor tell me that, this would happen? And then, the providers themselves saying, we're not doing a great job out there educating people, what cannabis hyperemesis syndrome is, which I think I mentioned to the students before. There are people who think, cannabis is for treating nausea, but actually you can actually have this overuse syndrome where you're throwing up constantly from it. And I've taken care of a couple people with it, and it's hard to convince somebody that they need to wash out completely. The state has some data about where is our current use. 17% adults have used cannabis in the past month. But there is also some spillage over. There's now increasing use in our youth. It's now 1 in 10 for our youth, whereas the biggest amount that's being used is in our young people, in the 20-year-olds. And then also some of this, that we see in some of the cannabis-related emergency department visits, or mostly in the 15 to 30-year-olds. And that one really caught my eye as a healthcare provider. And it really shocked me when I saw the numbers from this report. The previous report said, hey, the emergency healthcare utilization's just about 2,000. And I'm not quite sure if they pulled more data from cannabis use disorder, but not just poisonings and toxicity, but now it's 140,000 visits to the healthcare, to emergency departments. So if you're needing to go to the ER and you're like, I don't want to go to the ER because it's going to take 8 hours. Maybe it's going to take you longer than 8 hours now, because now we've got all these people going to the ER for feeling sick. And it's not just teens. You got babies with poisoning, you've got, but mostly it's, and young people too, right? Like maybe they found it at home. Oh, this is a gummy, let me eat it and see what happens. But we have teenagers, but it's mostly in that red area that you see the 15 to 30-year-olds where we see a lot of the toxicity or emergency department visits happening. So this is a concern, not only if you or I go to the health, emergency department healthcare, but it's also costing somebody a lot of money. Just briefly, some other things about cannabis use and health concerns. We're starting to develop more studies about this. So I mentioned the UCLA primary care survey that they did, where they found a lot of people, 1 in 6, using cannabis, even higher in 18 to 29-year-olds. And about a third of them over a third of them, rated moderate to severe risk for cannabis use disorder, and 3/4 of them were treating for some common symptoms like sleep, stress, and pain. And we were talking earlier about, needing to ask people about root causes of what they're doing. And then Kaiser did a very interesting study too, showing that prenatal cannabis use and maternal pregnancy outcomes, that there's an association with worse outcomes. This one, hopefully you guys can take a look at later, but also wanted to say for college students, we did a nationwide study of this and showed that using tobacco and cannabis, and if you use cigarettes, vapes, and cannabis, all three, it's associated with serious psychological distress in the past couple weeks. So we know that there's this mental health crisis already. Is it chicken or the egg? How is this happening? But we know that mental health is so important in our young people right now, especially coming out of COVID. Maybe these are not the best, things that we should be using to help with that. We need to help also support our young people in being free from these substances too. Finally, some final words on rising exposure in non-users. If we think of smoke as a cumulative load, we're getting exposed, 42% of us are getting exposed to cigarette smoke, vape aerosol, and now cannabis smoke. So, we need to be thinking about this total exposure. And also, it's not just adults, but also youth as well. And I think we were talking earlier about this idea about smoking in cannabis cafes. Why don't people just eat cannabis? People prefer to use smoking because some of it, what I've heard from patients also is, I can't control the high so well. But, this is going to, our lessons learned from tobacco control and public health. We even have smoke-free bars since 1998. And ventilation doesn't eliminate, all the risks that you have from smoke exposure. And even N95 masks don't protect you from gases or vapors. Treatment for cannabis, we don't have great evidence because, as mentioned before, this has not been allowed for study by the feds. But we do know that some of the behavioral health coaching, on dependence of substances, that this can maybe also be helpful for people too. Our Quit line has looked at some of their people who co-use both cannabis and tobacco, and they found that people who co-use cannabis actually have a harder time with quitting. And actually a number of them want to quit. So how do we help them? We don't have great meds to help them, but for sure we should be talking about it and probably screening for it as well. I also wanted to shout out to my Quit line colleagues that they have something called Y-Vape for the schools. So instead of being punitive, there's more of an educational approach to explain to people, what is the tobacco and cannabis products doing to you, and this is something that schools can utilize. So finally, some final thoughts, because I know I'm almost about out of time. And this is the part I don't have as many slides on, but this is where I hope all of you young people will help us think more of how to bridge some of these silos that we have and, systems change, policies. Just a brief mention of our Tobacco Cessation Policy Research Center. We just had our summit here a couple weeks ago, our first one, and we're funded by the TRDRP research program. And we are trying to work with community and academic partners to generate data for policy solutions that may help with some of these issues. So here's just a website. Also, you can see some of our policy briefs from our summit and our website. And we're trying to address, access to barriers to care. So like pharmacies, for example, our independent pharmacies haven't been able to get paid for doing tobacco treatment. Delivery of healthcare and substance use delivery facilities. Also, engagement on flavors. We created a policy brief that got to Governor Newsom's desk, and also working with healthcare plans to try to clarify coverage and also promotion of quality and equity. Finally, we're trying, my California Quits project, which is funded by the state tobacco program to help advance tobacco treatment with Medi-Cal, which covers about a third of our tobacco users in California. We now have to move to start asking about vaping. For 10 years, we were told not to ask about vaping products when we talked about tobacco. So we have a lot of stuff to catch up on and also educate the providers on the 3 different types of products out there. There's nothing requiring us to screen for cannabis. Lung cancer screening is another thing, and there's, I just want to let you guys know that there is this very slow process of quality metrics where we're hoping to try to align some of these tobacco quality measures and also include lung cancer screening, which is important. And there's a November Lung Cancer Awareness Month that the Assembly just passed a resolution for. Some final thoughts, on clinical and public health implications for cannabis. Again, healthcare, we're not screening. Even though there's so many people using, we're not saying something for health messages for this. We need to develop some of this health messaging and health screening, and what's going on in our schools, and who's paying for this. I think these are all bigger questions that we need to start talking together about. And finally, just some last reflections. This is all data, but it ultimately comes down to people and the people in front of us in our communities. So all the time we need to think, health and equity, and how do our policies help at the local and state level for our communities. Thank you.
Thank you, everyone, for coming today.